Day 2, palliative care, deliver care service using a palliative approach, CHC PAL 001, certificate 4 level, day 2, starting at PowerPoint number 31. Today we're going to start talking about pain. We'll start with pain. Pain's a huge part of palliative care. It's one of the things that we look for every day, and it's not so easy to find. Sometimes we have to ask a lot of questions. Sometimes we need to just keep watching for, as I've said earlier, grimacing, moaning, groaning when we're with them, and we really have to keep our eyes open for the pain. We do have an app now that can take a photo of their face and show the level of pain. It's amazing how far technology is coming to help us with this, but really at the end of the day, it's on us to be looking for pain. No resident needs to be in pain. We can definitely reduce pain or hopefully eliminate it for a few hours for them. So that's why this is an important part of the unit. So on with the PowerPoint. Pain occurs when something hurts, causing an uncomfortable or unpleasant feeling. The presence of pain often means that something is wrong. If a patient says they're in pain, believe them. That's going back to what I said last week and what we discussed last week. If the patient tells them that's hurting, believe them. Some people feel a bit defensive about this and say, I've done nothing wrong. You know, it's not me, I'm being gentle. And yes, that's all true. You probably have done nothing wrong. You have been gentle, but it's them. They're feeling pain. It hurts. It could be like, as we discussed, the feeling of when you're severely sunburned and someone touches you. It doesn't matter how gentle they touch you, it still can cause a lot of pain. So if they say they're in pain, don't think about you and what you've done. Think about the resident and what you can do to make it easier for them. As we discussed last week, we could maybe, if a resident is in a lot of pain and we've got to do cares, we could talk to the RN and organise for them to have their pain relief before we do their cares, or there are other things that we can do to help alleviate the pain while we're doing cares. I'm sure you've all got a few of your own tips here. We talked to the class about it last week and they were all kind of on the same page that normally the best way is to help have medication beforehand and then do their cares afterwards. Pain is a symptom, not a diagnosis. So pain is the symptom of cancer. Pain is the symptom of arthritis. It's not arthritis itself. So we can still, even though they are in palliative and are at the end of their life care, we're not treating the arthritis, we're treating the pain, which is a symptom of the arthritis. Okay, acute pain. Acute pain comes on suddenly and is caused by something specific. It is sharp in quality. Acute pain doesn't last longer than 6 months. It goes away when there is no longer an underlying cause for pain. Acute pain may include causes, of acute pain may include surgery, broken bones, dental work, burns or cuts. After acute pain goes away, you can go on with life as usual. So acute pain can be very, very painful. I actually suffered pain just a few months ago. I ended up with a deep vein thrombosis in my leg. The pain built and built and built until it was unbearable. In fact, excruciating. So acute pain can be excruciating. Anyone that saw me would have seen that I was in excruciating pain. I was rocking backwards and forth. I was curling up into the fetal position, clinging onto my stomach. I was teary. My color was very pale. I looked in the mirror and I couldn't even recognize myself. So you can notice pain in people when it's that bad, when it's excruciating. And it was acute pain because after a couple of days on the medication, the pain actually started to die off, and quite quickly, in fact, until it was no pain at all. So acute pain can come on suddenly, as it says here, and it was caused by something specific. For me, it was the deep vein thrombosis, the clots blocking off the vein. It is sharp in quality. Yep, sure is. And it doesn't last longer than 6 months. So as you can imagine, the causes here: surgery, broken bones, dental work. If anyone's had a severe toothache, it can also be excruciating. I know a lot of our residents, as you probably are aware of, teeth fall out, they have problems with their teeth. So be aware that dental work can be causing acute pain, burns or cuts. Hopefully we don't have to worry about that. And once the pain's gone, you can go on life as usual. Chronic pain. Chronic pain is pain that is ongoing and usually lasts longer than 6 months. This type of pain can continue even after the injury or illness that caused it has healed or gone away. A lot of our residents are on acute pain or suffer with acute pain, whether it be back pain, arthritis, lots of different reasons. A lot of them have learnt to live with the pain, and that's why it's tricky. If you ask them if they're in pain, they say no, not really. That's why we have a lot of other questions. And here I'll ask the students what other questions could be. It could be, are you hurting anywhere? Is it sore? Is something bothering you? Simple questions like that may get an answer, whereas if you're just simply talking about pain, they might not answer it. Because as you can imagine, if you've had chronic arthritis pain your whole life, you might not really know that you're in pain somewhere else. It might not show. So we have to ask questions. Is it bothering you? They might say, well, yes, actually, my stomach's bothering me. I've been getting some stabbing pain in my stomach. Just simple questions that we can ask, and then we can realize that, yes, they might have arthritis pain, but now they've developed this stabbing pain in their stomach. Pain signals remain active in the nervous system for weeks, months, or years. Some people suffer chronic pain even when there is no past injury or apparent body damage. Chronic pain is linked to conditions that include headache, arthritis, cancer, nerve pain, back pain, and fibromyalgia. Gosh, I've got to remember to pronounce that right. So once again, as it says here, chronic pain, people can suffer who haven't even had an injury or any apparent damage. There's residents, I should call them, there's residents in my facility at Woodport that might be now suffering from back pain from a fall they had maybe 30 years ago. They don't even remember having the fall. There's lots of reasons why chronic pain's there. People spend years going from doctor to doctor trying to find out the reasons for their chronic pain. Sometimes they can't find the reasons, but the pain exists for them. I don't understand it myself, but I do believe it. Sometimes the chronic pain for them can be behavioural. In our residents that have been in acute pain, they might remember that pain and consider it chronic. There are some now newer conditions that are coming out for chronic pain or suffering of chronic pain, like chronic fatigue syndrome and just chronic pain syndrome. So we're now finding that a lot of chronic pain that people could not really find reasons for are now being more aware of actually what's happening with chronic pain. Chronic pain syndrome is persistent pain that is carried on for longer than 12 weeks despite medication or treatment. And as I said, it can go on for years and years and years. So chronic pain is definitely something that we need to be aware as our residents are going into palliative. If you have chronic pain, the stress affects the body, producing physical conditions like tense muscles, limited ability to move around, a lack of energy, and changes in appetite. Someone that pops straight into mind is one of our beautiful residents that I look after. She can hardly get off the bed. She had a operation on her back for crushed discs in her back. She's had chronic pain ever since. Even the whole shape of her body's starting to change from the way that she's just constantly holding herself in one position. Her muscles are tensing up. Her limited ability to move around would be to the bathroom and back. She never leaves her room. She never leaves her bed. She has a lack of energy. Sometimes she finds it hard to even lift up her head. And she would nibble on a little bit of food. Obviously, not using as much energy. She hasn't got the appetite she should have. This is brought on by chronic pain. Some people might think it's behavioural. Some of it could be now. She might be able to come out to the dining room to eat. She might be able to join activities, but in her head now, the pain has taken over, and the pain that she's feeling, even though we're giving her pain relief, she shouldn't be feeling the pain. I can't get inside her body. I don't know exactly what she's feeling, but she's on quite intensive pain relief. She's still focused on the pain and the pain only. So it definitely does change physical conditions, as I said, just from this one person that pops to mind. I'm sure you've got some examples you can give me of people that are popping into mind if you want to share them now. We'll have a little class discussion on that. Even in the dining room, we have a few people with arthritis, as we mentioned before, the chronic pain of arthritis, where their hands have actually changed shape and they now need to have specialised cutlery and bowls to manage eating, even though they are in chronic pain. And they do have their pain relief. I'm sure they're feeling pain all the time, but they still can push through the pain and do everyday activities. So even with chronic pain, I don't want us to give up on asking them to the dining room, asking them to join into activities, all the things that make you feel alive, as we said, the spiritual connections to other people and all of that. We're still trying to maintain that through the palliative care and through chronic pain. Chronic pain also causes emotional or has emotional effects, including depression, anger, anxiety, and fear of re injury. This fear could limit your ability to return to work or leisure activities. So we've touched on the physical side, but we can't underestimate emotionally what chronic pain does to people. And as I said with the lady that before with the chronic pain from the back, she's in depression. She won't leave her room, won't leave her bed, and that's why sometimes it does seem behavioural as well, but that behavioural element could be depression. Well, it is depression. Anger, we hear the term cranky old man or cranky old woman as people get older. If they are in pain all the time, that anger could be misplaced as them being cranky and old, where really they're in a lot of pain. They've suffered with pain for a long time and they're feeling angry. I really can't blame them. I wouldn't want to be living with anger or living with pain every day of my life. I've started to develop a little bit of arthritis in my thumb. I'm sure it's from being a medicator and popping all those pills out, ripping open the packs. So I also feel a touch depressed and a touch of anger over arthritis. I feel I'm too young to be getting this. Why am I getting this? My thumb. I do have a little bit of anxiety even over it. Is it going to get worse? What's going to happen? Will my thumb change shape? Will I be able to use it? So I can understand the anxiety side as well. And the fear of re-injury. This fear could limit your ability to return to work or leisure activities. Yes, I think that that's definitely how I would be if my thumb was like this and I was in a lot of pain. I definitely wouldn't want to be doing a lot of activities. I'd probably just want to be back in my room. And I'm sure if you think about it, there's lots of residents around that would be in the same situation, feeling exactly the same. Some negative outcomes of pain is that it has the potential to hasten death. People in pain do not eat or drink. Inability to engage in meaningful conversations, isolation, and aggression. So why would the outcome of pain have the potential to hasten death? Ask the class what they think. Some of the reasons could be that they give up on life, they stop eating, which is the second one. People in pain do not eat or drink, so they stop eating, which could hasten death, especially if they still had months to live and could be living a good quality of life for the last few months of their life. Instead, they're refusing to eat and drink. It gives them the inability to engage in meaningful conversations. We've already discussed in how important it is for the residents to unburden themselves, to have conversations with their family. So the inability to engage in meaningful conversations could rob the resident of those conversations that they want to have or the families want to have with them. This also could cause their quality of life to deteriorate. Isolation. Once again, going back to my lovely resident who has the chronic pain and never leaves her room, never leaves her bed, and aggression. I think we've spoken about that as well. Reasons for untreated pain. Patient's inability to communicate due to delirium, dementia, aphasia, motor weakness, and language barriers. So if the resident is in delirium with maybe a UTI or an infection, a lung infection, or some other infection, it might be very hard to pick up. They're in pain. They won't be able to tell you. They'll be rambling. They won't know what's going on. They'll be hallucinating. So it would be very hard to treat pain to find out where they're in pain, for them to be able to isolate the pain, for us to tell us that they're in pain. Dementia, very similar to delirium, but obviously they're not through an infection. Same consequences, though, of the reasons for untreated pain, not being able to tell us what's wrong, not finding the right words that's wrong, not knowing how to point out the pain. So once again, really important for us to keep watching and looking for pain in our residents. Aphasia, motor weakness, and language barriers. Can anyone else in the class think of any other reasons why they might not be able to communicate their pain? They might think that if they admit they've got pain, that death is coming quicker. They might feel if they tell you that they're in pain, they might get medication which might drug them out. Lots of reasons why there's untreated pain. So we'll go through some questions, some good questions to ask our residents in palliative, and to pinpoint some of the answers we want to get from them. The first question, where does it hurt the most? Once again, by not using the word pain, we've taken pain out of the equation, and now we're asking them, where does it hurt? I think I've said in the past few slides that our residents, some live with chronic pain. So if you ask them if they're in pain, it doesn't really mean much to them. But if you say to them, where does it hurt the most? They might be able to say to you, well, my heart's hurting. I've got pains in my stomach that I don't normally have. It's just a really good way for them to point out where it hurts. So it's a valuable question. How bad is the pain? They may use a facility pain indicator such as a smiley face or rate the pain on a scale of 1 to 10. Well, I know we ask children that, so it's another good way to find out how much it hurts, especially for people with chronic pain. How bad is the pain? If they're saying 7, 8, or 9, we really need to be concerned, especially if their pain level's normally only at a 3 or 4. So once again, it's a really good way for them to let you know that the pain's more than it has been, or that they are in those high number of pains. How would you describe the pain? Sharp, dull, shooting pain. They're all very helpful when you go to the RN and you can tell her that your resident is in pain, and they stated it was a sharp shooting pain up their leg every time they walked, or a dull ache in their stomach, or they've got shooting pains going across their chest. A really good way for us to be able to help decipher the pain and to give the RN a really good chance to have a conversation with our residents. What makes the pain go away? What does make the pain go away? They might say to you, when you give me a heat pack, it helps the pain go away. That's an easy one. Get them a heat pack. They might say a hot shower helps the pain go away. Ice. They might know. They might have experience of what does help the pain go away. If they can give us any help or any experience of what they've used in the past to help the pain go away, it's very helpful to us. Are you able to sleep when you're having the pain? Some residents' pain happens at night. Once they lay down, they could have body pain, shooting pains, where they've been able to, I'm not going to say ignore it, but it might not have been so noticeable at the time. But when they're asleep, they notice the pain more. Are they able to sleep? If they're not getting a good night's sleep, that's another major concern we need to have. They'll only weaken them, fatigue, and all the things that we're trying to stop so they do have that quality at the end of their life. Does the pain interfere with your other activities? Is the pain stopping them going to activities? Is the pain stopping them from showering if they were somebody who showered every day? Is the pain stopping them from reading, knitting, some of the simple things they did? That's good to know. That could be very helpful as well, because that could give us a hint as to why they're not coming to activities, and we might be able to change the activity around to make it less painful for them, or to give them pain medication before they go to the activity so they can once again get that quality of life, that social interaction, and be able to do their activities. Ask them, what do you think is causing the pain? They're the experts of their own pain. They'll know, especially if it's chronic, what's causing it. They might say to you, well, I went out today with my daughter and we did a lot of walking. Now I'm in more pain. They might know. So it's good to ask them anyway. As I said, they are the experts of their own pain. And what have you done to alleviate the pain in the past? A little bit of the similar question to what makes the pain go away. What do they do? What have they done to alleviate our pain? Myths about pain. Dying is always painful. No, that's not the case in a aged care facility. Dying is not painful. It's something that we're aware of, something that we're closely monitoring. Care staff are closely monitoring that. RNs are closely monitoring it. Doctors are closely monitoring it. Families are closely monitoring it. So dying is not always painful. In fact, dying is not painful in aged care facilities. So when you think about palliative, we've got a really good idea of how our residents want to pass. Some kinds of pain can't be relieved. In our facilities, we try to relieve all pain. Most pain, even if it can't be relieved fully, if it's a chronic pain that they've had, we can really work well with morphine and get most of the relief done with heat packs. So we can relieve most pain. Sometimes the relief is short-lived and we need to be doing PRN medication in between the medications or heat packs, but we can relieve pain. Most pain can be relieved. Pain meds are always cause heavy sedation. We don't like heavy sedation in our aged care facilities. We don't believe in it. The senses are the last thing to go, so we want our residents to still be able to have quality of life even at the very end with their family, to be able to have conversations with their families, to at least be able to hear conversations with their family. We don't like to heavily sedate. A lot of our residents at the end are sedated. They are in a very peaceful, sedated place, but they're not heavy sedation, so they can hear and still know you're there, feel you touching them, hear those conversations, still smell if we've got the aromatherapy in the room, still hear the music. So no, pain meds don't always cause heavy sedation. I should save my use of strong pain relievers until real close to the end. This isn't true. I've done this myself and it doesn't help. Strong pain relief is, some of them are 4 hourly, some of them 6 hourly. They've got different kind of doses, so saving them doesn't help. Some pain relief we can give 6 hours, as I said, but we can also use a 4 hour in between that, so we are always topping up their pain relief. So there's no need to ever save any of their pain relief until the end. Remembering that some residents don't even need pain relief. It's totally individual and up to the resident themselves. Hopefully they will have filled out an advanced care directive and will have let us know how they feel about pain relief before they get to this stage anyway. I can get immune to the effects of pain relief. Once again, we're talking about end of life. We're talking about the last few weeks or days. We're not really worried about our residents becoming immune. We can up the doses that's up to the RNs and the doctors. If we feel that they're not getting enough pain relief from what they have at the moment, we can also do PRN in between. So yes, people can become immune to the effects of pain medication, but once again, we're bringing this back to palliative to the end, and we're not really worried about our residents becoming immune, as we can give the stronger doses. Once on pain meds, you always have to increase the dose. No, not true. Not true. I have a lot of residents that I have medicated that their doses don't increase at all. They're quite comfortable on the dose they have, and it works for them. But as I said before, we are talking about the end of life here, and if the dose needs to be increased, we can increase it. We have that ability to increase it. It's totally up to the doctor, RN, family, and up to the UCAS care staff to be looking out for pain, to be monitoring the pain. If they're having pain while we are rolling them, to wash them. If they're groaning, grimacing, if you can see it in their face, it's up to us once again to remember to let the RN know so we can monitor their pain. If it needs to be increased, it will be, but it's once again an individual thing up to what the resident requires. Only injections give you good pain relief? No, once again, we give a lot of oral pain relief. Ordine is oral. We give subcut straight into the muscle, so that's not true. We don't like to give injections. We don't like to be prodding them with injections all day long, so no, you can get good pain relief from patches, oral, and subcut. Pain medication use always leads to addiction. Once again, this is a myth. If you're using your pain medication as prescribed, you won't become addicted. People become addicted when they abuse their medication. And anyway, once again, we're talking about last months of life. You will not become addicted. Withdrawal is always a problem with pain medication. As I said, we're talking about end of life. We won't be withdrawing them. Withdrawal is not always a problem. Sometimes, with some different kinds of medications for depression and all that, you have to slowly come off the medication, but not with the use of morphine or the pain relief we're giving at end of life. Enduring pain and suffering can enhance one's character. Oh, this is a good one. Not trying to stereotype or anything, but when you've heard of cranky old men or cranky old women, I once again wonder if they're in a lot of pain. As we know, with pain, it can come out with aggression, anxiety if you're not dealing with it. So it's not enhancing one's character. You're not tough. You don't have to live through pain. It will surely come out as an unmet need later on. Once they start giving you morphine, the end is near. Once again, we have people on Ordine and different types of morphine, and they've been taking it for years. It's not near the end. It is associated, obviously, with end of life, and it's a very common used medication at end of life because it's so effective, but it is not indicating the end is near. People have to be in a hospital to receive effective pain management with morphine. No, morphine can be delivered at home. You can deliver it anywhere. People can actually be walking around with morphine on a pack and be dosing themselves. You do, if you are at home, you do have to get daily prescriptions of morphine. If you're in a facility, we will have it on hand and the RNs will give out the daily morphine. At this point, I haven't put it into my slides, but I will be looking up. I did find a great YouTube on the myths about morphine that is really good to watch. If I have time, I'll pop it at the end for you to watch. If not, I really recommend you looking it up yourselves. Medication. People with life-limiting and terminal illnesses will often be required to take many medications. That's true. We do have people who are on a lot of medications, but that's not always the case. Some residents decide to stop taking their meds. Sometimes we will just give them like Coloxal or what they need, maybe something for cramps. And some of them will take a lot of medications depending on what their illness is. But remember, we're not treating the illness anymore. We're only treating symptoms now. So once again, this would be very individual and would be the choice maybe of a advanced care directive. They might say that they want strong pain medication not to feel pain. They might say they want to go off all their medications. Some medications are given to control and slow down the process of a disease. These are often called palliative treatments. They may include chemotherapy, hormone treatments, and radiotherapy, all of which can also be curative treatments. Yes, they can be curative if the disease or condition can be cured, but also we can use them to lessen symptoms. So even though the cancer now is at that stage where it can't be healed or cured, sorry is the right word, they may still choose to take some chemotherapy. They may still choose to take these treatments. It might relieve their pain. It might help them. Once again, that's a very personal decision, which would be a conversation including them and their family and the RNs and doctors. Other medications may be given with the aim of managing and or preventing symptoms associated with a palliative condition. That's what I suggested earlier. They still might be on their Coloxal, they still might be on medication for cramps or indigestion. I mean, they might be on palliative for quite a while, so we don't want them to have symptoms of other conditions. It's individual as well, but we still don't want our residents to have constipation. We still don't want our residents to be cramping up. We still don't want them to have conditions like that. Obviously, we don't want to be giving them heart medication and medications that will, prolong their life when the rest of their body is obviously shutting down. In a palliative approach to treatment, giving medication should be as simple as possible and support the person's quality of life. We always look to how the best way is to give medications. Sometimes we crush medications. Sometimes we give them subcut, as we suggested earlier. We can give them in liquid forms. So whatever we feel is best way that they get that medication is the best way we will deliver it. Medications should frequently be reviewed, and some medications may be stopped as they are no longer working or needed. Some medications may also be stopped if they are causing more harm than good. Once a resident is put on palliative, they will have, as we spoke about last week, they will have their own care plan. They will definitely have their medications reviewed, and as suggested here, most medications will be stopped. If they're causing more harm than good, as I said, if they're actually keeping the heart working when the body is shutting down and all their other organs are shutting down, that would be causing the body more harm than good. That is one example that I can think of. The classes of medication most commonly used in palliative care are analgesics to treat pain, antiemetics to treat and prevent nausea and vomiting, laxatives and aperients to treat and prevent constipation or diarrhea. Steroids may reduce a range of symptoms related to inflammation. Antidepressants to treat depression or sometimes pain, and other neuroleptic medications to treat depression, anxiety or pain, delirium, and sedatives to assist with calmness or sleep. So these medications are what we were talking about in the last PowerPoint. They're working towards quality of life rather than working towards keeping the body keep ticking by and causing more harm. Morphine. Base drugs should be given subcut at end of life if the patient is unable to swallow or absorb medications. They are less painful given this way rather than the intramuscular route. Diamorphine is 3 times stronger than oral morphine. One of the reasons morphine is also given is it relaxes the body, relaxes the twitches, relaxes the breathing. It's very good. It works with the signals for the brain to work hard. As I suggested, I will try and get that PowerPoint of morphine up on here for you to watch at the end. It gave great information and the class really enjoyed it. Heat packs can aid relief of chronic musculoskeletal injuries and associated pain. Don't ever underestimate the heat pack. They give great relief and can be used constantly. We have people buzz for heat packs all day long, and it's something that we can give to relieve the pain. It does relieve pain, but it also helps with behaviors. It relaxes the body and is, as I said, is a great way to ease the resident and to give them that pain relief. Relaxation techniques. Massage. Gentle massage can relax and relieve tension. Sometimes, our residents at the elder age don't want full body massages or want massages. Younger clients who palliative can get a great relief from massage. But I know our wellness team will go around and give hand massages, which once again is a lovely time to spend with the resident. Gives them the touch, which we know the senses are still there. Gives that feeling of touch, connection. You can have a nice conversation with them. Helps them feel connected to other people, as well as the relief of gentle massage can give. Aromatherapy. Some essential oils may help alleviate nausea or fatigue, while others may help with anxiety and depression. Aromatherapy is a great, once again, to connect back to the senses. I think that PowerPoint comes up a bit later. Be careful though with some oils like peppermint and all that, because they awaken the body rather than give you that calm sense of calm. So you don't want some oils. Peppermint's one you wouldn't want to use. There are a few, so if you are using aromatherapy oils, always check with your RN or the wellness team or whoever has the information that can really help you with that. Music can be soothing, relaxing, nurturing, energizing, or comforting. It may reduce anxiety and stress and promote relaxation. It could create joy and bring back happy memories. Everybody loves music. Music is international. It's around the world. Everybody has connections to music somewhere in their life. Everybody has fabulous memories of music. Some music can bring back sad memories. Remember the old breakup CDs or cassettes, if you are old enough to remember those, where you'd sit and listen to your breakup songs. They might bring back sad memories, so maybe you could check with the family if there's any music that best suits the resident. But background music, once again, can give so much to our residents, helping them to connect to memories and reminiscing, as well as making them feel relaxed. Think of when you're having a massage and the relaxation music's on, how relaxed we feel, and that is just through massage, touch, and music hearing. Signs of end of life. So we're moving on now to the end of life. I think most of you will be or have seen these signs. We'll go through them. Circulation, mottling of lower extremities. Mottling is sometimes used to describe uneven, discoloured patches on the skin as a result of cutaneous ischemia, lowered blood flow to the surfaces of the skin. I know when our residents are at the end of life and we repositioning them or rolling them to wash them or get them dressed, I can see the modelling even going up their back. So it's very noticeable. As I said, you all would have seen modelling and you'd know exactly what it is when you see it. If you haven't seen it, you would recognise it and then you would know it. Pulmonary, the death rattle, a medical term that describes the sound produced by someone who is near death when saliva accumulates in the throat. This can go on for a couple of days. It can go on for a couple of weeks. As I said previously, if you haven't heard it before, once you hear it, you'll recognise it. You'll know, okay, I know what that sound is. It can upset families. We just have to comfort the families and say this is a part of the end of life. It doesn't cause any pain. It doesn't give them any discomfort. It doesn't affect their breathing. As we said, it's just that accumulation of saliva. Cheyne-Stokes respirations is an abnormal pattern of breathing characterized by progressively deeper and sometimes faster breathing, followed by a gradual decrease that results in a temporary stop in breathing called an apnea. This happened to my nan. My nan was with my mum at the end of her life, and when we were sitting with her, she'd take a deep breath, and sometimes 30 seconds would pass and we'd be thinking, oh no, has she passed on? And then all of a sudden she'd go, ah. So it was quite frightening at the start, I have to admit, but then after a while we did get used to it. So my nan definitely had the apnea breathing, but I have also heard residents with the faster breathing, the panting, the once again, this doesn't affect the residents. It doesn't cause them any pain. It's probably more worrisome for the families that are sitting with them. They might ask you about it, but it is very normal at the end of life. Signs of end of life. Skin. The skin can come clammy, dusky, go grey, and be coolish to touch. When everything's slowing down, when the body's slowing down, you will feel that. You will see their colour change to a greyish colour. They will feel clammier and cooler to touch. That is just everything slowing down in the body. And the eyes. It's funny how you can see it in the eyes. Discoloured, deeper set, bruising appearance. They kind of shrink and sunken. Look to the eyes. Strangely enough, I have seen residents that this happens to their eyes, but then when they pass on, that kind of moves away and their eyes can look very peaceful, and the bruised appearance and the discolour can almost go away and give them a very peaceful look around the eyes. Hallucinations and visions, especially of long gone loved ones, can be comforting. If seeing and talking to someone who isn't there makes the person who's dying happier, you don't need to try to convince them that they aren't real. It may upset them and make them argue and fight with you. Hallucinations and visions are different. People who have sat with their families have told me or told people that their family have seen visions while they are cognitive and in a relaxed state, not while they're hallucinating and restless and not sure what's going on. I myself have seen several times residents reaching up to the sky. I've seen residents talking to people that aren't in the room. And I have seen residents, well, I've had conversations with residents who have told me that they've had conversations with their past ones, or people they don't know, but people who were there to help them. I have to say this makes me happy and makes me feel more comfortable for my own End of Life, if you've seen it, doesn't matter what you believe in. If you see it yourself, it is comforting. So I can imagine it's making the resident very comfortable to know that someone's there with them. I do have a PowerPoint coming up a little bit later that I highly recommend you to watch, that explains all of this, and I once again found it very comforting. There are lots of residents that don't get visions, and once again, or don't tell of visions and all that, and once again, that's perfectly normal. Each person's an individual and will pass differently as long as they have that quality life in the end. Once again, I've added a YouTube here. I recommend you watch that. And unfortunately, we won't be able to discuss that, but we will be discussing that with the class a bit later after the YouTube. When to start end-of-life medication. Noisy breathing is an indicator of impending death, occurring in about half of people who are actively dying. It can sometimes be referred to as respiratory secretions, gurgling, and the death rattles. Once we do hear the breathing change, it is a very high indicator for us, and we will start looking at our resident hourly, checking on them, making sure they're not in pain, and if they do need pain, more pain medication, stronger medication. So it is a great way to look at starting that end-of-life medication. Dysphagia, difficulty in swallowing, is expected in the terminal phase and necessitates a switch to the subcutaneous route. This is an excellent way to give medication. I have done it for years with RNs. Well, I haven't done it, but I've been there when the RNs have done it. It causes no pain. It's quick, it's effective, and is the way that we go at Woodport, and I imagine it'd be the same at Peninsula. It's the best way to deliver that medication at the end of life. At the end of life, what would we expect? Obviously, there'll be an absence of pulse, breathing ceases, pupils are fixed and dilated, the body becomes pale, body temperature decreases, muscles relax, urine and feces may be released, eyes may remain open, jaw may fall open, and a trickling of fluids internally can be heard from the resident's body. If you've worked at Peninsula long enough, as I imagine you will have, you will come across an end-of-life resident. It is exactly as it says here. Mostly when I have come across an end-of-life resident, I see it in the eyes first. Sometimes there is just that last breath where the body does relax, the eyes are fixed, and it's almost visual for the ones I've seen. You can actually see the end of life. We do still have to require the RN to come in and confirm end of life. They will do vitals, they will check for the absence of pulse. That's their job. They do that, and they will confirm death, and then they have their processes where they have to contact the doctor and contact the family out there and start their processes of end of life, and that's when we start our processes. This one down the bottom, the trickling of fluids internally can be heard from the resident's body. That really threw me the first time. The first time I rolled a resident at the end to give them a wash down. I heard all these noises. It was a little frightening. I thought, what's happened here? But now I've become to know it is normal. So if it is your first time, just be aware that you might hear noises of fluids still making their way through the bodies. Okay, following death. Following confirmation of death by the RN it is crucial that a person's dignity is maintained immediately following their death. So follow any cultural or religious rituals provided. If there is any cultural or religious rituals, we will be told about it beforehand. You'll be told about it in handover. It will be general information for all the care staff. Mostly, if there would be any cultural or religious rituals, it would be the family that would be providing those. Some people like a priest to come in just before death so they can do the last rites. There could be some rituals. It's not common. I've only come really across the priest maybe coming in to say the last rites, even if that is the way that the family would like for the resident or the resident would like, we still can proceed and get the resident ready for the family and the priest to come in. Any other rituals or cultural requirements, as I said, would be told at the time. So what we need to do, if possible, is to close the person's eyes. Some suggest place their arms down by their sides. Personally, I like to have their arms up under their chin with their hands together, one hand out of the sheet so the family can hold on to the hand, but that's either or would be acceptable. Replace dentures as soon as possible. It's very hard to get dentures in after a certain time, so if you are there at that time, if you can get the dentures in straight away, that is very helpful. A lot of families like to see their loved ones with their dentures in and still have that dignity and respect for their dentures to be in. Gently wash the body, remove any devices and tubes. At this point, you can take out catheters, take off stomas, anything like that can be removed at this time. They're no longer needed. As we're washing the body, dressing clean clothes. This is really important to families and I believe to the resident. Dress them how they like to be dressed. I had a situation where the family came up to the office and they were really distressed because their dad was dressed in odd pajamas, different top to bottom. So just remember, this is a really distressing time for the family. So please just be aware of when you're putting them in clothes. Make sure it's clothes that they loved. We all know our residents, we know how they looked, what they like to wear. So dress them in nice clean clothes. Place a rolled towel under the chin so their faces do not sag. Get that up nice and tight. You can pull the sheet up over so it's covered and all very neat. It sometimes doesn't work. Even if you do put that there, the chin can open, the mouth can open a little bit, but still try your hardest to get that up and under. Strip the bed, put clean sheets on if required. We normally do that anyway. And clean the room, make the space comfortable for family and friends to say their farewells. At this stage, throw away or get out, all empty tubes of creams, mouth swabs, all that clinical stuff, all the stuff that we use for their cares. Move all that away, get rid of all of that, make the room beautiful. This is a time where I still like to talk to my resident while I'm doing these cares, these final cares. I like to tell them, that I enjoyed spending time with them, little personal things that I might have to say. It's up to you if you like to do that or not. Some staff will come in while you're doing this and maybe want to say their goodbyes. It's totally up to you. Some people believe the spirit hangs on for a while, so if you have these conversations, if that's how you feel, the spirit's still in the room, you might feel that final connection. Otherwise, it might just be for yourself, just being able to have that final conversation. Any questions? Legal and ethical considerations. First of all, even through palliative dignity of risk, right up to the end. It's up to them to decide how they want to live their life, their quality of life, if they want to get up and go outside. Funnily enough, I've had residents right up to the very end who still want to go out the day before they die, go out and have a cigarette. That's their choice. We still give dignity of risk. They still have the human rights, which you can see down there, of anyone. So dignity of risk and the human rights still stand. Duty of care, our duty doesn't change. Of care doesn't change. Privacy, confidentiality and disclosure. If you are in the room while you're doing cares and you hear something from family that's private or confidential, once again, right up to the end, keep that private. Work role boundaries, responsibilities and limitations. At the very end, you know, the family might ask you questions like, how long has mum got to live? Questions like that. We can't answer questions like that. If they want to ask questions like that, that's a question to the RN or to the doctor. Don't step over your boundary even at the end. We're not doctors, we're not counsellors. So remember that we can give comfort, we can give empathy, we can give all that, but just remember your work role boundaries. Relevant policies, procedures, protocols and practices of the organisation. I have checked with Peninsula. They don't have anything really around end of life, just still your codes of conduct, your legal duties, which always is. I think there's a question on this when it comes up to legal. Remember, legal is always discrimination, privacy. So remember those when the question comes up. And ethical is human rights and, you know, respect. All the human rights would be ethical. Remember at this time too, there's a responsibility to yourself and to colleagues. So if you're feeling extreme grief or one of your colleagues are, or stressed over the feeling, remember stress is a hazard and a legal obligation to report it. So remember yourself. Most facilities will have somebody that you can speak to. We have chaplains. At Peninsula, you could maybe talk to Nikki or somebody, talk to your colleagues. Don't bottle it up. And also, this is a good time to remind you all that you have 5 free counselling sessions. These counselling sessions can be used for all sorts of things. They can be used for private, personal issues, they can be used for work issues, and they can be used for grief. So remember those and take advantage of them if you feel you would like some more time or more conversation about the grief you might be feeling. As I mentioned earlier, senses are the last thing to go. Remember, the senses are the last to go and play an important part of palliative care. They make us feel human and connected with the world. Smell brings back pleasant memories, great smells that we can use. When my nan was palliative at Mum's house, in the morning I used to put a little bit of her 4-7-11, dab a little bit behind her ears that she wore every single day. And in the evening she wore tweed, so in the evening Mum would spray a little bit of tweed on her. That made her happy. When I put the 4-7-11 on, even when she was very towards the end, sometimes she'd say to me, nice, which made me feel connected to her. So making, as I said, that human connection. Smell, some people like flowers, some people love the aromatherapy. So yes, smell definitely is a very strong connection. Touch brings back connection with loved ones. We all know how important it is at the end of life, if you're with one of your loved ones, to be able to hold their hand, to be able to feel them, how important it is for us. It's just as important for them. They can feel that touch. It does bring back connections. It does definitely comfort them and make them feel loved. So don't feel scared to touch your loved ones, to hold their hand, to talk to them. Hearing is the last to go and gives comfort to our loved ones. All those things you wanted to say, this is the chance to say them. Talk to them, love them, play a bit of background music. Be careful with some music, it might overstimulate them, so be careful of your choices. But choose music they loved or liked, and once again, that will bring them back to that connection, maybe the family connection or their youth. My grandmother was a ballroom dance teacher, so I liked to play some waltzes and all that for her. Once again, I believe that made her feel connected with her past, maybe brought back some pleasant memories for her, but it also made me feel like I was doing something for my nan, and it gave me that connection with her. It's really, I put this PowerPoint up because it's really important to remember at palliative and at end of life that little things are not so little. Meaning, maybe going out and watching the sunrise or watching the sunset can bring great joy. Maybe a drive to the beach, going outside, sitting in the garden. These are the things that will bring joy to and memories to you and to your loved ones at the end of life. A walk around the garden, a conversation, a sunrise, a sunset. Don't underestimate the little things. A 5-minute conversation, a little hand rub, something special. They don't have to be big gestures anymore. Sometimes just going back to the very basics of life is what is important to our residents at the end of their life. I have now a couple of YouTubes coming up. A Day with Terminally Ill Patients. This is an excellent YouTube. I got a lot of good out of that. I highly recommend you watching that. We will be having class discussions, but you can watch it and make your own opinions up of it. Actively Dying, another YouTube that we'll watch through with the class. You've got it here, you've got the link here, watch that. LDAC. This is a series of YouTubes. I've added this. If you want more information, they're an excellent site to go to. They have great information. I've added this link. I highly recommend you look at it through your own time and maybe go onto their website. There's some really great information there for you. Suiting the Needs. We actually watched this YouTube to start the course. You all watched it and answered some questions on it. It's in here again in case you wanted to look at it, but you have seen this one. I've added a few more YouTubes in here. I think the first one is the one I really want you to watch. It's the lady who talks about the visions and hallucinations. I found it very interesting, and I think you will as well. So if you get the time, watch the YouTubes. They're very informative. You are also, as I suggest to the class, there's so much information out there, so many YouTubes. If you want to look for your own or have a little look, or if you're interested, and I think I spent a whole day just watching YouTubes. I got quite sucked into them all, so be careful. There's hundreds of them out there. So if you feel like you want a bit more information, look to YouTube. There's plenty of information on there about palliative, about end of life, what happens to you after life, different cultures, how they view dying. So there's so much information out there. I highly recommend, if you're interested, to take a little look at some of the other YouTubes out there. But I've added these two for you to look at. As I said, I think it's the first one that I really like. We're going to talk about grieving next. I know this is a touchy subject. Some of you in the classroom, if it's too upsetting, I'm more than happy if you want to leave for this part of the course. I myself have not dealt with any grief other than grandparents residents and all of that, so I haven't dealt with any real personal grief like some of you might have. So yeah, so if you find this too much, please leave the room now. And if you find I'm a bit clinical about grief, I'm sorry if I am. It's, as I said, something I haven't felt really deeply myself. But it's also a part where I'm more than happy to have great class conversation, and hopefully we can share our feelings and share how we've maybe experienced grief ourselves, or anyway, good time for us to have discussions here. The 5 stages of grief: denial, anger, bargaining, depression, and acceptance. The reality of grief is they won't come in any, or these stages won't come in any order. They'll overlap. They will be all over the place. Denial. I've still watching the YouTubes and talking to people. You know, people still say, "Oh, I still hear the door open and expect them to come through." Things like that. Anger, we can understand. Bargaining. Take me, why didn't they take me? I've lived a long life, you know, why did they take somebody younger, you know, why can't we swap? Depression and acceptance. I think they're all pretty self-explanatory, and as you can see from the second diagram, how they all overlap. Grief isn't neat, it's not a nice straight line, it doesn't go through the stages like a bouncy ball, you know, it is really, really messy. And it's personal, and everyone deals with it separately and differently. There's a few more. I found this one interesting as well. There's a few more stages that some people like to put in. They've still got the shock, the denial, disorders been added in with this one, anger, guilt and bargaining. We've talked about distress, depression, loneliness. If you've got some of those lovely residents, I'm sure you do have, where their partners come in every day, the wife might come in every day and assist their husband with their meals and spend all day with them. They're going to be very lonely, withdrawal and acceptance. And once again, the reality of grief, as you can see in the second picture, is all over the place. It's very messy, very personal, and anyone who has felt this type of grief will understand the diagram. Everyone experiences grief in their own way. There is no correct way to grieve and no way to fix it. Feelings. We may experience intense feelings such as shock, chaos, sadness, anger, anxiety, disbelief, panic, relief, or even numbness. Some people are fearful as they are adjusting to a loss that may be, Some people are fearful as they are adjusting to a loss that they may forget or lose connection with the person who has died, or may even feel disloyal. I just want to go back to with relief, feeling relief. It seems strange that grief can come with relief, but remember, some of the residents are old and their children have watched them suffer and go through long, prolonged diseases or diagnoses. They will feel some relief in a way that has finished. That doesn't mean they won't feel all the other feelings as well. And they could also, which isn't here, and having talked to some of the residents with their families members, they might feel relief, but then they will feel guilty about feeling relieved. So it's a very chaotic, as it says, time for your feelings. Thoughts. We may experience confusion and find it difficult to concentrate. It is not unusual for people to have extraordinary experiences, such as dreams of the person who has died, or have a sense of their presence. Mostly these are comforting and will help us feel close to the person who has died. We may think that we will never get over this, or that we are going crazy. We may think that this is all too hard and wish we were with the person who has died. This is an expression of our pain and sadness. Watching all the YouTubes, and even speaking to family members and students of past and all that, it's amazing how many people tell me that, for example, their mothers loved butterflies, and they will see butterflies at certain times when they're feeling sad or distressed. They might see a butterfly, or all different things. One lady told me about a tomcat that their mum said, I'm coming back as a ginger tomcat. And the day that the husband had to sell the family home, a ginger tomcat walked into the house. So these, who knows what they are? Are they the family members popping in, checking in, making sure all is good? I like to think so. It's up to you what you think, but there's definitely lots of stories out there. Physical reactions, sometimes we may have trouble sleeping. Grief can also lead to physical symptoms such as tiredness, loss of appetite, nausea or pain. If these symptoms persist, check with your doctor to exclude other causes. Relationships can be affected. Sometimes we will be preoccupied or tense or feel disinterested in other people and things. Sometimes you just need a bit of space before you can enter into, the loving relationships you had. You might feel a bit empty, void of feelings. That hopefully will pass, and you will be able to tap back into the other relationships in your life. Behaviours, we might experience lethargy or overactivity, pay little attention to self-care, sleep a lot, desire to resort to alcohol or non-prescription drugs, and other potentially harmful behaviours. Well, we all know with behaviours, some people are overeaters, some people don't eat, some people will drink, some people will look to drugs, some people might do a bit of online shopping. These behaviours happen all through our lives, not just with grief, with stress, with hard times and all that. So I think we would be familiar with those behaviours. And beliefs. Our beliefs about life may be challenged. Often grieving people wonder why this has happened to them. I've heard people that are really solid in their faith question God, question their faith at times like this, which is all pretty normal and natural. If we are with teammates, families, members that are grieving, or you yourself are grieving, once again, remember that we are there to comfort family members, comfort each other. We are a team, and let's look out for each other and let's help each other through this. Self-care. Acknowledge your grief and recognise that this is a normal reaction to loss. Talk to your supervisor and colleagues about what you are experiencing and request their help or support from a professional counsellor if needed. Develop a self-care plan and strategies that promote your physical, emotional well-being. Self-care strategies may be different for everyone. Select one that works for you. Look after yourselves. We do a tough job. We deal with grief a lot. Sometimes we might not recognise how it has affected us. We might think we're okay about grief. It might come up a week later. We might just all of a sudden feel this intense sadness. But just look after yourself. As I said, it's a tough job. It's tough giving 100% of yourself to the job. And, we go home. We don't have a lot of time for ourselves. We're tired. We've still got to maybe look after families. There's still, things that need to be done. So the stronger we feel and the better we look after ourselves, the more we can give to our families. So please look after yourselves. Get regular exercise, eat healthy, regular meals and stay hydrated. None of us drink enough water. Well, I suppose there's some out there that do, but the majority of us aren't drinking enough water. Make sleep a priority. try a relaxing activity, get connected, and report to your manager or your staff if you're feeling burnt out, angry, lack of concentration, scared, teary. As I said earlier, stress is a hazard, and so is some of these feelings. We don't want to take it out on our residents if we lose control. So make sure you report to your manager how you're feeling. Thank you for your time through this course. I've enjoyed spending the time with you. It's a really important course. There now is looking to be a core subject in the certificate. I think it will be really beneficial. I know it's hard for new staff to go out onto the floor and have to experience palliative. It would be great to go out there with some experience. I think we all probably remember our first time we dealt with palliative residents and one of our residents passing on. So once again, thank you so much. Be kind to each other, be kind to yourself. If there's any questions, please feel free to ask.